you know, it's for the first look, you think that this is a very easy topic, and maybe you think it's not important, but it has a very, very important single best answers, as I said, that can become in the exam. So as it is an easy part, but you cannot miss it at all. Okay. Okay, first I'd like to start my lecture by the overview of this lecture. Okay, actually we'll talk about the skin and fascia and the muscles of anterior abdominal wall and the inguinal region anatomy. Okay. Okay, first I'd like to start to talk about the skin. Okay, the skin of the abdomen has some important points that we need to focus on that are related to our exam. Okay, first I'll talk in a quick about the layers of the anterior abdominal wall first, which are arranged from outside to inside. First, the skin, then the superficial fascia, then the musculoaponeurotic plane, or the muscles and the aponeurosis, or the muscular layer, then the transversalis fascia, the extraperitoneal fatty layer, and the parietal peritoneum. Okay. Okay, first, we'd like to talk about the skin. It has some important issues that are related to our exam, as I said, and these are am I audible? Everyone, please, can you write in the chat book if am I audible or not? Okay, so I'm audible. Okay, thank you. Thank you for your interaction. Okay, the skin, okay, the most important thing in the skin is the skin incisions. Okay, the most important part in the skin, the incisions, we need to know that we have two types of skin incisions. Okay, the first type is either vertical skin incisions or transverse skin incisions. Okay, for the transverse skin incisions, we have two main types of transverse skin incision. The first one and the most common one that we are using is the steel incision, okay, which is a curved transverse incision, approximately 10 to 15 centimeter long, with average length about 12 centimeters, okay? No voice, or there is a voice? Please, who are not opening the voice, voice check again, voice check. Do you hear me, guys? Am I audible again or not? Because some students are writing in the chat box that there is no voice. Okay, audible. Is my voice clear for you? Is it clear? Yes. Thank you for your introduction. Okay. Again, the steel incision is a transverse incision, as I said. It's approximately 10 to 15 centimeters long, with an average 12 centimeters, okay, length, and 2 centimeters above the symphysis pubis. Okay, this is the most important point that you need to know about the steel incision. Okay, the skin and the rectus fascia in this way of opening the abdomen. Okay, it's open transversely using a sharp dissection. The rectus muscle are not cut, and the fascia is dissected along the rectus muscle. Okay. The second important transverse skin incision is Joule-Cohen incision. Okay, this is a straight transverse incision through the skin. Okay, it's about 3 centimeters below the level of the anterior superior iliac spine, which is higher than the phalansteal incision, okay? This technique, the subcutaneous tissue and the fascia are opened in the midline and extended laterally with a blunt finger dissection, okay? Blunt dissection is used to separate the rectus muscles vertically and then open the peritoneum, okay? The most important things you need to know for part 1 exam is the part that highlighted with line below it, okay? We need to know where the incision is laid exactly in the abdomen. This point you may be asked about, okay? Okay, what about the vertical skin incision? The vertical skin incision or the midline incision, these are begins at the symphysis pubis and extends superiorly to the umbilicus. It can be extended further around and above the umbilicus as necessary, okay? Okay, now let's talk in a hurry about the differences between the advantages and disadvantages for each skin incision type. I mean, either vertical or transverse incisions. And Dr. Helmi will have another webinar and he will talk in more details in this regard, plus the nerve injury, okay? First, let me start with the vertical incision, okay? The advantages of vertical incision that are excellent for exposure, okay? Easy to be extended. And median incision is least hemorrhagic, plus minimum nerve damage as we are opening in a vertical manner, okay? Rapid entry to the abdomen and pelvis with median incision, okay? The disadvantages, it's more wound dehiscence and hernia may be more frequent in the vertical incisions, poorer cosmetic results, and higher rates of hemorrhage, especially increasing the operative time with para-median incision type, okay? Regarding the transverse incision, advantages, it has best cosmetic result, okay, because it's we are opening in transverse manner, which is in line with the horizontal skin lines, okay? Plus, it's less painful, less post-operative pain, and less interference with post-operative respiration and greater strength, okay? The disadvantages of this type of incision, more time consuming, plus more hemorrhagic, and compromised ability to explore upper abdominal cavity if we needed to extend the wound. Okay, these are the advantages and disadvantages for each, and you know to know these points. Okay. Let's come to talk a little about the fascia of the anterior abdominal wall, which is the second layer after the skin, okay? The fascia of the anterior abdominal wall have special characteristics, okay? There is no deep fascia here. Can you tell me why, friends? Can you tell me why there is no deep fascia in the abdomen?
Good evening, Miss. To allow distension of the abdominal organs.
Excellent, doctor. Very excellent. Yes, because of the possibility of distension of the abdomen, either in pregnancy, either in obesity. So we need this space to be easy flexibility and movement, okay? And that's why there is no deep fascia investing the abdomen. It's only superficial fascia after the skin, okay? And again, the superficial fascia is furtherly divided into two layers. The superficial layer, which is the fatty layer, and it's called the Camper's fascia. I'm sure that all of you, you know this name, you are very familiar with this. The second layer, which is the deepest superficial fascia, it's the membranous, the fibroelastic membranous part. And this part, actually, it's very interesting interesting because it's extending down to the pelvis to invest the pelvis in the superficial perineal fascia. Okay, if you looked here to this picture, this is the superficial fatty layer. Okay, and this is the deep layer here. Okay, the deep layer investing the whole abdomen and extends down in male to be investing the penis. Okay, and again it will invest the testis, and here it will name as a dartos fascia. Okay, while in females it's down here. Okay, the membranous layer, it comes down to invest the pelvis and to be attached to the superficial perineal fascia. Okay, that will cover the whole pelvis. Okay, so it's easy to imagine, or it's important point to be put in mind, that the abdominal cavity and the pelvic cavity are invested in the same superficial fascia, the same membranous fascia, which is in the abdomen called the scarbus fascia, while in the pelvis it's called the colus fascia. Okay, I need you to remember this point very well, because there is a practice question applied on this point. Okay, please don't be panic when you read such a question. Okay, a urinary catheter is vigorously inflated in the urethra at the time of cesarean section. Urine leaks from the rupture into which anatomical space? Is it leaking into the anterior abdominal wall and mons pubis, or into the lesser pelvis, or into the peritoneal cavity, the vagina, or laterally to the femoral triangle? What do you think, guys? Can you write in chat box which the correct answer?
A.
A. Okay. I need more answers.
A. Into the anterior abdominal wall and mons pubis.
And mons pubis. Excellent. So this is applied to this point that we are talking about, okay, that the fascia here, so the answer is A again. Let me come back to the picture, okay. This is the membranous layer here. As you can see, it's coming down from the abdomen down to the pelvis, okay. So here is the urethra here. If there is urethral injury anyway, so the urine will be leaked out to the abdomen here through this space. So it's not possible to imagine this idea because you already understand this point. Okay, is it clear now? Is it clear?
Clear.
Okay, thank you. Okay, let's see the other layer. Okay, as we can see, we started with the skin and we talked about the important characteristics of the skin, then the superficial fascia, then now the musculoaponeurotic layer, or the muscular layer of anterior abdominal wall. Okay, and here the abdominal wall muscles are divided into three bulky groups. Okay, the first one, anterior wall muscles. Okay, and the lateral wall muscles, or the anterolateral muscles, and the muscles of the posterior abdominal wall. Okay, in this lecture we will focus more on the anterior abdominal wall and the lateral wall muscles. Okay. Okay, before we proceed in more details in these muscles, we need to know the functions of the anterior abdominal wall muscles. Okay, they flex the trunk. They are accessory muscles of respiration and forcible expiration and coughing. They are used in defecation, micturition, and parturition. plus they protect the abdominal viscera against trauma. Okay? Okay, now we will talk about the muscles of anterior abdominal wall in regard the origin and insertion. Okay, we will start with the rectus muscle, which is the only vertical muscle or longitudinal muscle. Okay, it's the rectus abdominis. It's originating from the fifth to the seventh costal cartilages. Okay, and inserted down to the pubic crest. Okay, so it is the longitudinal muscle that are divided in between by which is called the linea alba, which is the tendinous insertion of the lateral wall muscles in the center. Okay. And the anterolateral muscles are three: the external oblique, internal, and transversus abdominis. From outside to inside, the external oblique is originating from the outer surface of the lower atribs. It is inserted in xiphoid, the linea alba, all the length of the linea alba down to the pubic crest, the pubic tubercle, and the anterior half of the iliac crest. Okay. About the internal oblique, it's the second muscle from out to in. It's originating from the lumbar fascia laterally and the anterior 2/3 of the iliac crest plus the lateral 2/3 of the inguinal ligament. Okay, and I want you to remember this point very well because we will talk about it later. Okay, that the internal oblique muscle is originating from the lateral 2/3 of the inguinal ligament. Okay. Again, the internal oblique is inserted in the lower 6 costal cartilages, the linea alba, and the pubic crest. Okay. Please bear in mind that these three lateral muscles are innervated by the anterior primary rami of T7 down to T12. Okay. The transversus abdominis, it's the third inner muscle, okay? It's originating again from the lower 6 costal cartilages, the lumbar fascia, the anterior 2/3 of the iliac crest, the lateral 1/3 of the inguinal ligament, and it is inserted in the linea alba and pubic crest. Okay, what about the rectus sheet? This is a very, very important point and you can be asked about it in exam. Okay. The rectus sheet is formed by the aponeurosis of the two oblique muscles and the transversus. Okay, it's a fibrous sheath formed mainly by a split in the aponeurosis of the internal oblique muscle to enclose the rectus abdominis muscle. Okay, as you can see, this is the rectus abdominis muscle, the longitudinal muscle. Okay, and take focus that this aponeurosis that investing this muscle from down and these tendinous parts here. Okay. If we talk a cut section in this sheet, we will find this picture. Okay. As you can see, this is the rectus muscle on each side. In between, this is the linea alba. Okay. And it's actually divided into two parts mainly. Parts above the arcuate line, which is the demarcation of the entry of the inferior epigastric vessel to the rectus sheath, and we will talk about this point in details further on. And the other part is below this arcuate line. Okay. As you can see here, first, above the arcuate line, which is from the costal margin down to this point of the arcuate line, in front of it, in front of the rectus muscle, is the external oblique muscle, okay? Posterior to the rectus muscle is transversus abdominis and the transversalis fascia. But in between, there is the internal oblique muscle, which invested into two parts, anterior lamina and posterior lamina. The anterior lamina covering the rectus muscle from anterior, and the posterior lamina investing this muscle again posteriorly. So above the arcuate line, anterior to the rectus sheath is the external oblique muscle, the anterior lamina of the internal oblique muscle, while posteriorly the posterior lamina of the internal oblique muscle, the transversus abdominis muscle, and the transversalis fascia. Okay? What about the part that's below the arcuate line? Okay? Here, all the muscles, either the external oblique, internal oblique, or transversus abdominis, are lying in front of the two recti, okay? While the transversalis fascia lying posterior to these rectus muscles. And this finding, this anatomical fact explaining why when we are opening for cesarean section, we don't find a posterior rectus sheath. We only find anterior rectus sheath because below the arcuate line, the aponeurotic part of these three muscles are lying anterior to the recti, and there is no aponeurotic part posterior to the recti muscles, only the transversalis fascia. Okay, I hope that it's clear. Is it clear?
Yes, ma'am.
Okay, thank you. Okay, as I said, okay, it can be again furtherly divided into three parts. The uppermost part, it's almost always not mentioned in too much box because it has no details. The upper part or the first part above the costal margin, okay, the anterior leaf, external oblique only, while there is no posterior leaf because it's adherent to the costal cartilages, as we said, from the 5th to the 7th costal cartilages, okay? The second part from the costal margin to the arcuate line of Douglas again, and I'd like to remind you that the arcuate line of Douglas is the landmark of the entry of the inferior epigastric vessel to the rectus sheath. Okay, anteriorly it is the external and the anterior leaf of the internal oblique, as we said, and posteriorly the posterior leaf or posterior lamina of the internal oblique plus the transversus abdominis and the transversalis fascia. Okay, while in the last part below the arcuate line, as we said, all the three muscles lying anterior to the rectus abdominis muscles, posteriorly there is no muscles at all, only the transversalis fascia. Okay. Okay, this view is posterior view to the rectus sheath, okay, explaining the entry of the inferior epigastric vessel in what's called the arcuate line of Douglas, okay. Above this line, from here, all the three muscles, all of them are anterior to the rectus muscle, okay. And posteriorly, as you can see here, there is nothing except the transversalis fascia. Okay. Okay, now it's important to know, it's crucially to know, because this point is very, very important and you can ask it about it in the exam, contents of the rectus sheath, okay? Contents of the rectus sheath, you can divide them into 2, 2, 2. It's easy to be remembered, okay? 2 muscles, 2 vessels, and 2 nerves, okay? 2 muscles, the rectus abdominis muscle, and plus the pyramidalis muscle. It's a small triangular muscle down and anterior to the rectus abdominis muscle, okay? This is number 1. Number 2, 2 vessels, which are the superior and inferior epigastric vessels, okay? Inferior epigastric vessel coming from here, we will talk later from where it's originating exactly, and the superior epigastric vessel is coming from the internal thoracic artery. They are forming anastomosis in the posterior part of the rectus sheath. Okay, so the second content is 2 vessels, which are the superior and inferior epigastric vessels. Okay. The third component of the rectus sheath is the nerves, which are 2 nerves actually, the lower 5 intercostal nerves plus the subcostal nerve. Okay, so very easy to be remembered as this way: two muscles, two vessels, and two nerves. Okay, here it's time to talk about the inferior epigastric artery. It's very important one for us as obstetricians and gynecologists because it's in the area of the field of our work, either in the laparotomies or the laparoscopic entry, okay? So it's most commonly to be injured. And again, Dr. Helmi will talk in details in this regard, okay? The inferior epigastric artery arises from the external iliac artery. Okay, this is the external iliac artery. By the way, this picture is taken from inside, not from the outside. It's like drawn from the inside of the abdominal cavity. Okay, so this is the external iliac artery, and this is the inguinal ligament. Okay. So again, the inferior epigastric artery arising from the external iliac artery superior to the inguinal ligament, as you can see here, okay? Then it ascends up, okay? Then it will skirts to the medial margin of the deep inguinal ring. This is the deep inguinal ring to ascend up and medially to get enter to the rectus sheath in what's called the arcuate line of Douglas. Okay, so this picture is very nice, showing this course from inside. Okay. Inserts the rectus sheath, as we said, at the level of the arcuate line, which is this. Okay, above the umbilicus, it forms an anastomosis with the superior epigastric artery, one of the terminal branches of the internal thoracic artery. Both superior and inferior epigastric arteries perforate the recti muscles to supply them and continue through the anterior wall of the rectus sheath to supply the skin of the abdomen. Okay, so this is very, very important artery. It's important to know where it's originating from, okay, because it is very important point for single best answers. It's originating from the external iliac artery. Okay. The inferior epigastric vessel raises a fold through its course, as we are showing here. Through this course, it's covered from inside by parietal peritoneum, okay? So because it's covered by this part of peritoneum, it will raise it up and causing a fold. This fold actually is used as a landmark, okay? The inferior epigastric vessel raise a fold of parietal peritoneum and form the landmark of the lateral umbilical ligament on the deep surface of the anterior abdominal wall, lateral to the medial umbilical ligament, okay? So as you can see, this is the median umbilical ligament. This is the medial umbilical ligament, and this is the lateral umbilical ligament, which, as you can see, coming from the external iliac artery, ascending up and medial to cause this fold, which is called the lateral umbilical ligament. This is very important point in single best answers. Okay, it's important to mention what's called ligaments of peritoneum, okay? It's a bunch of ligaments that it's crucially to know for single best answers, okay? Umbilical ligaments, either median umbilical ligament, okay, or medial umbilical ligament, and the lateral umbilical ligament. The median umbilical ligament, which is in the center, it's the remnants of what's called the urachus, which ascending up from the bladder, it's the remnant of the allantois, okay? This is the median one, okay? Then the medial umbilical ligament, it's again the remnants of the umbilical artery, okay? The lateral umbilical ligament, as we said, it is fold raised by inferior epigastric vessels, okay? There is another ligaments you need to know that are the ligamentum teres, it's the remnants of the umbilical vein, and there is another a ligament by the peritoneum called the falciform ligament, runs from the umbilicus to the liver, okay? This slide is very, very important for single best answers. Okay, now let's come to what's called the nerve supply of the anterior abdominal wall. It's important to know. Okay, the anterior abdominal wall is innervated by the anterior primary rami of T7 down to L1. Okay, where the T7 supplies the xiphoid region, like here. Okay, and the T10 extends to the umbilical region, and in between T7 and T10, the other nerves supplying the abdomen, like T8, T9, down to T10 in the region of the umbilicus. Okay, what about the subumbilical area or suprapubic area, like here? It's mainly innervated by the L1, okay, where the L1 divides on the posterior abdominal wall to form the Ilio Hypogastric and the Ilio Inguinal nerves, okay? This is the Ilio Hypogastric and the Ilio Inguinal. They are originating posteriorly from the lumbar plexus, and they are originating from, again, the anterior primary rami of the L1. Okay, the Ilio Hypogastric runs deep to the external oblique, just above the inguinal canal, to supply the suprapubic skin. Okay, while the Ilio Inguinal traverses the inguinal canal in front of the round ligament. It emerges either through the external inguinal ring or through the adjacent aponeurosis to supply the skin of the anterior part of the labia majus together with the skin of the adjacent upper thigh. Okay, so the Ilio Hypogastric supplying the suprapubic area, while the Ilio Inguinal comes down to supply the area of part of the area of the mons and the labia majus. Okay, is everything clear up to now, friends?
Yes.
Yes.
Okay. Okay. Now we will talk about very important area again for single best answers, which is the inguinal ligament and the inguinal area anatomy as all. Okay, what is the inguinal ligament? Okay, the inguinal ligament is the lower fibers of the aponeurosis of the external oblique muscle. Okay, come on guys, the anterolateral muscles, which are external, internal, and transversus abdominis, are coming from laterally to be originating in the center and down. Okay, and before they are inserted, they are transforming into aponeurosis, which is shared aponeurosis between those three. Okay, so it will come like a tendinous part down there. Okay, so the inguinal ligament is the lower fibers of the aponeurosis of external oblique muscle, which from the anterior superior iliac spine, okay, like here, starts from here, anterior superior iliac spine, to the pubic tubercle down to here, okay, is thickened and folded on itself to form the inguinal ligament like this, okay. This enfolding forms the floor of the inguinal ligament, okay. What is the conjoined tendon? Remember when I told you that you should remember the insertion of the internal oblique in the lateral 2/3 of the inguinal ligament? Do you remember?
Yes.
Okay.
Yes.
Yes.
Again, the internal oblique, okay, and the transversus muscles. The transversus muscle is inserted in the lateral 1/3 like this in the inguinal ligament, while the internal oblique is inserted into the lateral 2/3 of the inguinal ligament, okay? Then they are forming shared fibers to be hooked up for the inguinal canal to relate superior to it, and again to be inserted here in the pubic tubercle to be forming what's called the conjoined tendon, okay? So again, the conjoined tendon is the fusion of the internal oblique and transversus abdominis, inserts to the pectineal line here and the pubic crest. Okay, so by this, it will cause anterior relation to what's called the deep inguinal opening. Okay, as we will explain later on. And at the same time, it will form posterior relation to the superficial inguinal opening. Okay? Again, it can be called the falx inguinalis, which lies behind the superficial inguinal ring of the inguinal canal to strengthen this weak point in the abdominal wall. Okay, so from deep to superficial. Okay, this is the transversus abdominis. Okay, but before it, deepest, this is the fascia transversalis. Okay, then superficial to it, the most lower fibers of the transversus abdominis, and more superficial to it is the internal oblique and the external oblique. Okay, so the superficial inguinal ring is like the opening or defect in the external inguinal muscle. Okay, or external, sorry, oblique muscle.
Oblique
okay
muscle.
Yes, and the deep ring is the defect in the fascia transversalis here. Okay, which is, as I told you, it's strengthened by these fibers. Okay, so this is the falx inguinalis. It has 3 relationships to the inguinal canal, as we will see later on. Okay. Okay, what do you know about the lacunar ligament? Okay, what is the lacunar ligament? Okay, in this picture, this is again the anterior superior iliac spine. Okay, and imagine that this is the pubic tubercle. Okay, this is the inguinal ligament extending from the anterior superior iliac spine down to the pubic tubercle. Okay, this is part from the superficial fascia extending down to invest these vessels. Okay, so it's forming what's called something like a ring. Okay, and forming here something like a sheath. This sheath is called the femoral sheath. Okay, while this is formed like a ring. But before that, we need to know the boundaries. Okay, if you notice that the inguinal ligament extending from the anterior superior iliac spine down to the pubic tubercle, then it go back posterior and laterally to be inserted in the pectineal line. Okay, this arcuate shape is called lacunar ligament, and it's part from the inguinal ligament. Okay, and it's forming the medial boundary of what's called the femoral ring. Okay. Okay, so the lacunar ligament, it's part of aponeurosis of external oblique that is reflected, as you can see here, reflected posterior and medially from the inguinal ligament, okay, backwards and laterally to the to be inserted here, as we said, in the pectineal line, okay. What about the femoral sheath? Okay, the femoral sheath is derived from the extraperitoneal intra-abdominal fascia. As we said, it's extended down to investing this structure. Okay, it's formed anteriorly from transversalis fascia, posteriorly from iliacus fascia. Okay, and it contains what? Contains the femoral canal from medial to lateral, femoral canal medially, femoral artery, and the femoral vein. Okay, And please bear in mind that it doesn't contain the femoral nerve, okay? Please don't be confused with this because it is the femoral branch of genitofemoral nerve that's coming from up the lumbar plexus, okay? But the femoral nerve is lying outside this sheath, okay? And this is very, very important point to be asked in single best answers, okay? So from medial to lateral, again, from medial, the femoral canal, the femoral vein, and the femoral vein, then the femoral artery, okay? Okay, what about the femoral ring? Okay, the femoral ring, it forms the entrance to the femoral canal, okay? It's oval in shape, as you can see. It's larger in females. Its diameter 1.25 centimeters, and it contains only fat and lymph node, okay? So this relationship is important to be asked in the exam as they are arranged medial to lateral, okay? The femoral canal, the vein, and the artery laterally, and the most important point, that the femoral nerve lying outside this sheath, okay? Is it clear up to now?
Yes.
Okay, so only you, friend, you are answering. There is no other doctor answering. You can write in chat box. Come on, I need to see names. Is it clear or not?
Excuse me, ma'am.
Yes,
Can I
go
ask
ahead.
you a question?
Yes, sure.
There is a difference between what's written in the box below and the picture. Which one is right?
Yes, the picture is right, but the box is not. Okay.
Okay, so
It's
the
only
vein is
typing
medial.
error. Only typing error, okay?
Vein is medial, then the
Then
artery
the
is
artery.
lateral.
Yes, yes, dear. Yes.
Okay, thank you,
Okay.
ma'am.
Okay, thank you.
Thank
Thank you. Okay, so shall I proceed?
Yes, please.
Yes. Yes.
Okay. Now we will talk in a hurry about the differences between the deep inguinal ring and the superficial inguinal ring, okay? The deep inguinal ring is an oval opening in the fascia transversalis, as we said, okay? Lies about half an inch, okay, above the inguinal ligament, midway between the anterior superior iliac spine and the symphysis pubis. Okay, margins of the ring gives attachment to the internal spermatic fascia. In male, okay, about the superficial inguinal ring, it's triangular in shape. Defect in the aponeurosis of external oblique muscle, lies immediately above and medial to the pubic tubercle, and its margins, sometimes called crura, okay, gives attachment to what's called external spermatic fascia, again in male, okay? Okay, so what's the inguinal canal? Okay, if you remember the picture that I have showed to you, that it's an imaginary tract between the deep inguinal ring or defect and the superficial inguinal defect, okay? It's about 1.5 inch or 4 centimeters long in adults, okay? Extends from the deep inguinal ring downward and medially to the superficial inguinal ring. Lies parallel to and immediately above the inguinal ligament, okay? And it's a newborn child, the deep ring lies almost directly posterior to the superficial ring, because whenever the person increase in its height, these two rings are separated from each others, okay? So the length of this canal is about 1.5 inches or 4 centimeters, extending from the deep inguinal ring to the superficial inguinal ring, okay? It's very, very important to know the walls of the inguinal canal, okay? The anterior wall is formed from what? From the external oblique aponeurosis, okay, which is reinforced laterally by the origin of the internal oblique from the inguinal ligament, okay? It contains superficial inguinal ring medially, okay? The posterior wall is formed from the conjoined tendon medially, okay? The posterior wall formed from the conjoined tendon medially, okay? And the fascia transversalis laterally, like it's clear in this picture, okay? It contains deep inguinal ring laterally here, like here, okay? So the anterior wall is formed from the aponeurosis of external iliac muscle, which is this in the anterior wall. This is the defect of the superficial inguinal ring lies in the medial part of it, okay? The posterior wall is formed medially from the conjoined tendon, okay, laterally from the transversalis fascia, and it contains the deep inguinal ring, okay? The roof or the superior wall is forming from the arching lowest fibers of the internal oblique and the transversus abdominis, as they are hooking above the inguinal canal and forming the superior part of it. The floor is formed from the upturned lower edges of the inguinal ligament and the lacunar ligament medially, okay? Okay, what is the function of the inguinal canal? Okay, the inguinal canal in males, it is the passage from the for the spermatic cord from the testis to the abdomen. Okay, from outside to inside, plus the ilioinguinal nerve. In females, it is the passage for the round ligament of the uterus from the uterus to the labia majus from inside to outside, plus the ilioinguinal nerve. And this is very important point for single best answers, as like what does the inguinal canal transforms, okay, or transport? It's transporting the round ligament in female and the spermatic cord in male, plus the most important ilioinguinal nerve, okay? Okay, and this is very beautiful picture for the round ligament as it's originating from the cornea of the uterus, okay, and ascending upwards and laterally to enter the inguinal canal through the deep inguinal ring, and then transformed through the inguinal canal to be out through the medial superficial inguinal ring. Then it will insert it down to the labia majora, and this is again a very important single best answer, as where does the round ligament insert it? Okay. Okay, so this is the last slide for today. I hope that it's clear and I hope that you got benefit. Any questions? Is there any question before we move to the last part, which are practicing questions?
Please, I want to ask a question for you.
Yes, go ahead.
About the contents of rectus sheet.
Yes.
There is two muscle and two vessel and two nerves.
Yes.
I know
right.
before. Okay. I know before there is the 6 nerves. Yani about the lower 5 intercostal nerves
Yes.
and the subcostal nerve.
Yes, you are right. But just for the purpose of making it more easy, we
Yeah.
made it like two nerves. Okay.
Okay.
It's
Thank
better
you.
for you to
Okay.
memorize it like this. Okay. It's as
Thank
you can see here, two
Yes.
nerves. Okay. The lower
Okay.
5 intercostal nerves and 1 subcostal nerve. Okay.
Okay.
So
Nice.
it's made like more easier way to be remembered. Okay.
Okay. Thanks.
Thank
Can
you.
we ask another question?
Yes, sure. Go ahead.
There is a very common question. What is the nerve which is the nerve must be injured during the beneficial incision and the cesarean section? from understand from the talk from you about the hypogastric nerve which are injured or no?
You know, for the answer of this question, I'd like you to attend Dr. Helmi's webinar, which will be very soon, okay? I will not answer it now, just for you to
Okay.
get the webinar and get a good understanding with Dr. Helmi, okay?
Okay, thanks, doctor.
Okay, dear. Thank you. Thank you.
I'm
Any other
happy
questions?
with you.
Thank you. Thank you, dear. Okay, good luck. Any other question? Okay, so let us go for the last part of this lecture, which is practicing questions, okay? And I need volunteers, okay? I need one volunteer to practice this question. Come on, volunteer.
Can I
volunteer.
please?
Yes,
Okay.
sure, honey. Go ahead and read the question.
The median umbilical ligament is the embryological remnant of what fetal structure?
Yes.
A is gubernaculum, B umbilical arteries, C umbilical vein, D urachus, E is vitelline duct. The umbilical median is urachus, D.
Yes, excellent, honey. The answer is D. Thank you. Thank you very much. Okay. I need another volunteer, please. Volunteer, volunteer.
Okay, can be.
What's your name? What's your name?
My name is Amna.
Okay,
Amina.
go ahead, Dr. Amina.
Okay. The superficial inguinal ring is strengthened posteriorly by what structure? A. Falcus inguinalis, B. Puborectalis, C. Recti abdominis, D. Superficial inguinal tendon, E. Transversus abdominis. A. Falcus inguinalis. That is the second name for the conjoined tendon.
Yes, excellent, Dr. Amina. Thank you. Thank you.
Okay.
The key is A. Okay. Can you do the third question? Dr. Amina?
Yeah.
Go ahead.
Okay. The inguinal canal transmits the round ligament and which important nerve? A. Ilio Hypogastric nerve, B. Ilio inguinal nerve, C. Obturator nerve, D. Pelvic splanchnic nerve, E. Duodenal nerve. The
Your
answer is
answer?
B. B. Ilio inguinal nerve.
Are you sure?
Yeah.
The key is Ilio Hypogastric.
Why? Inguinal canal transmitted the round ligament and which important nerve? Ilio inguinal nerve. B.
B, yes. The
Yeah.
answer is
Yes,
right.
I think also it's B.
Yes, it's
Yeah.
B, but it's written A. Okay, the answer is B, ilioinguinal nerve. So you are starting to be masters. I'm very happy. Thank you.
Okay.
Thank you.
Thanks.
So the
Thanks
answer is B, huh? Okay.
Yeah.
Which the third volunteer for the fourth question? Who is the volunteer?
Function of the anterior abdominal wall muscle are flex trunk, act as accessory muscle for respiration, help in defecation, picturation, barbituration, parturition, protect abdominal organ from trauma. E, all of the above. The answer is E, all of the above.
Excellent. 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 Come on, I need another volunteer. Thank you, Dr. Amina.
Thank you.
There's only 3 questions left. I need another volunteer, please. Come on, there is around 17 attendees here. Only Dr. Amina?
May I take this question?
Sure. What's your name, honey?
Maysoon.
What's your name? Maysoon.
Maysoon.
Yes, 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 yes. Okay. And here is the question.
Okay.
Yes. Go ahead.
This one, inguinal ligament, which extends from superior iliac spine to pubic tubercle, represent Ruled out lower border of external oblique aponeurosis. Ruled out lower border of internal oblique aponeurosis, or ruled out lower border of transversus abdominis, both A and B, or all above. It's external oblique, A.
A, excellent. This is external oblique. Yes, the key is A. Okay, can you do the next question, please?
Yes, please.
Go ahead.
Anterior abdominal wall is innervated by posterior rami of T7 to L1, anterior primary rami of T7 to L1, anterior primary rami of T9 to L1, anterior primary rami of T9 to L1. It's B, anterior rami of T7 to L1.
Do you think it's a posterior rami? Or
No, I
anterior
think
rami?
I think it's anterior rami.
Yes, excellent. The answer is B, anterior rami of T7 down to L3. And the last question, please.
Suprapubic skin is supplied by Ilio Hypogastric, genitofemoral nerve, ilioinguinal, femoral, or obturator. It's Ilio Hypogastric. A.
Don't you think it's B?
Genitofemoral?
What do you think?
No, I think it's A. Ilio Hypogastric.
Yes, excellent. It's ilio hypogastric nerve, as ilio hypogastric nerve supplying the suprapubic area, and the genitofemoral nerve supplying parts of the mons and the labium majus. Okay.
Okay.
Thank you, doctors, for attending this lecture, and I hope you got benefit, and I hope that anterior abdominal wall anatomy is clear for you now.